welcome to G News, the good news.
Yeah, right.
Hello there. Hi, it's really good to be talking with you in person at last. My name is Gerard Otto, and this is the very first podcast for G News for 2025. Today we're going to be talking about our health, and in particular we're talking about how the New Zealand health system is going through a crisis, and we're also going to be talking about some of the barriers that are faced by women trying to access health in New Zealand. Today I'm joined by Dr Orna McGinn, who is a general practitioner and the chair of the New Zealand Women in Medicine's Charitable Trust. Hey Orna, how are you doing?
I'm very well, thanks, G, and thanks for inviting me.
You're welcome. Orna, you began working in medicine in the UK and you started off working in the NHS, and then 14 years ago you came to New Zealand. What kind of difference was obvious to you when you looked at the New Zealand health system compared to the NHS?
So I didn't know a lot about New Zealand's health system before I moved here. And I remember talking to a friend who worked in public health in the UK. And she said, do you realise you're going to a system which actually is one of the most inequitable in the world? And I said, what are you talking about? I hadn't even thought about that. She said, well, New Zealand has some of the greatest disparities in health outcomes between populations of any country in the world. And that really surprised me. It's not something that I was expecting. And I came here, and that was one of the things that I really noticed, and also that it was openly discussed at that point, and there was a real will to do something about it. So I think from as soon as I arrived, I think New Zealand was accepting of the fact that, you know, its Māori and Pacific populations particularly had huge inequities in outcomes, and there was a very pronounced difference in life expectancy. But what was really galvanizing at that time about beginning work over here as a GP was the fact that it was acknowledged, and there were concrete moves to do things about it, and we were fully invested in that in general practice. So that was one of the biggest things that I noticed, and we'll probably talk a little bit about perhaps how that landscape has changed. And the other thing that I noticed was a heavy reliance, even back then 14 years ago, on the private system. So I was quite used to, in the UK, a very small minority of people being privately insured. It was very expensive. It was actually not really seen as necessary. I think at that stage, again, we're going back a while now, 14 odd years ago, people were terribly proud of the NHS and the fact that it was free at the point of access and accessible to everybody. And I came here, and obviously the most noticeable thing for me as a GP was that money changed hands every day, that suddenly people were paying to see me, and that was kind of anathema to me. That was very unusual. I mean, it's very strange to me that we are the gatekeepers and people pay to see us in primary care, but the more expensive secondary care interventions ostensibly are free. They don't cost anything, but obviously they are terribly expensive and people pay for them in their taxes. And when I go back to what I was saying about the reliance on the private system, here, even since I got here, between 30 and 35% of the population have had private insurance. That has crept up over the years, and now it's more than 45% of Aucklanders are privately insured. And that is a marked difference. It's increased reliance on the private system, meaning that we've basically got two health systems working here, often working against each other rather than together.
There was obviously a lot of concern about what to do with the public health system because in 2019, the Health and Disability Review, led by Heather Simpson, recommended that we simplify it and that we take those 20 DHBs and reduce them down, that we introduce an organisation called Health New Zealand, and that we bring about a Maori Health Authority and to address inequities, and that we seek a much more integrated approach to the continuum of healthcare. Did any of that really happen from your experience?
Well, I suppose I can speak from the point of view as a sort of, jobbing GP, working GP. It's very difficult to see what has changed for us and our patients, to be quite honest, from this enormously disruptive reset of the health system. Change was absolutely needed. The health system in New Zealand for a small country is too complicated. It's inefficient. It's bureaucratic. It could do so much better. The will is there. There are incredible people working within the health system, but it just seems to be really hard to get things done. So when I think the whole of the country were given the opportunity to input into the Heather Simpson report and look at the Health and Disability Review, people really poured their hearts and souls into submitting to that, because if you get a once in a generation chance to sort of talk about what the ideal health system may look like, a publicly funded health system in a small, well functioning, well governed country, it could look pretty amazing. And the report, when it came out, had the support definitely of the vast majority of the medical profession. Then, of course, the next thing, as with every report, you need to work on an implementation plan. So then, out of this fell the PIORA legislation. So this is where things probably began to get a little bit off track. So as part of that PIORA legislation, there was always going to be a focus on Māori health, Pacific health, and rural health. And a lot of the medical profession, certainly women in medicine, lobbied very hard for a women's health strategy as part of that. So that was included and that was passed. So we're going back to 2022 now, I think it is. Anyway, that all of these strategies seem to have sunk like a stone. So it's difficult to say what has actually been achieved by passing the legislation. And that's always the thing, isn't it? You pass legislation. Is it going to be enacted?
Right. Yes. Well, we hear a lot of blame being cast around, particularly from the current Prime Minister, Christopher Luxon, concerning what happened during the pandemic and the fact that there was a reorganisation of the health system during a pandemic. But I've heard quite a lot of comment that the crisis in the health system was definitely just exposed by the pandemic. It was already there. It wasn't the pandemic that created the crisis. It was already present. And now we've got the public slowly realising that we really do have a crisis in public health. Do you have any comment to make about that?
Well, I think it is really important that the public do realise that the health system is in enormous difficulty, and it's at a crossroads, and I think it is the voting public who, if they feel strongly about the health services that they are entitled to as taxpayers, if they feel strongly about that, they do need to speak up. There are still enormous inequities in New Zealand. They're getting worse every day. And unless there is a significant improvement, we are probably going to end up with a very different looking health system in 5 or 6 years' time. If we have a greater move towards reliance on private health, for instance, this will literally just hollow out what's left of the public system. And I suspect what people don't realise that is, even if you are privately insured, you will still need a public health system if something acute happens to you. If you develop chest pain, a heart attack, if you have a stroke, if you have a car accident, or some other incident that results in a major trauma, you will not get treated in a private hospital. You will need the public system, and we cannot just rely on increasing use of the private system, because we're not making really any more doctors and nurses, and so they have to work somewhere. And if they choose to work in the private system, well, they can't work in the public system. So it's a zero-sum game.
Yes, I heard that we have gone from having something like 40% of doctors working in primary care down to something like 20%, or that we were 600 GPs short in New Zealand. And increasingly, the kind of patient experiences have changed. We're now waiting longer to see a GP, and when we do see a GP, we have maybe 15 minutes. And the people that are really caring about us, the doctors that are very empathetic, they're suffering from exhaustion and burnout. And what kind of factors have contributed to this feeling that everything's just slowly getting worse and worse for GPs?
Well, it's definitely not just for GPs. I think everyone working within the health service is feeling the strain. It's most people who are going to work in health do it because they enjoy having a job where they genuinely feel that they're doing something worthwhile. You get so much positive feedback every single day. It makes you happy to go to work, even if you do one small thing as a nurse or a doctor or a lab technician or anything. But if you work in a system which does not enable you to do your best work, that over time becomes really stressful. What we've been hearing in Women in Medicine, we conduct an annual workforce survey, and we've done that for the last 3 years. And the issues affecting the workforce are becoming more profound every year. It's really obvious. The rates of burnout are increasing. 1 in 15 doctors who answered our survey this year have taken stress leave in the past year. That's quite a stark statistic. What's leading to this? So you really basic things like being undervalued. So your voice is not being heard, and that includes things like if you have colleagues who are on sick leave or maternity leave, planned leave, or they leave or they retire. Often the jobs are not re-advertised just to save money, so you're stretched in a department, and then this often leads to a sort of a vicious circle where the workload increases such that more people leave, then you've got individuals who have even more work heaped on them, and all of a sudden you have a department that's collapsed. And we know of departments where this has definitely happened, and in particularly vulnerable specialties like psychiatry and obstetrics and gynecology. There was a lot of publicity recently about the department in Whakatane losing all of its obstetricians. So there is a crisis due to workload, and also just a feeling that there is no clear direction of travel for the health system. I think when we're going back to the prior legislation, when that was passed in 2022, I think we felt that there was a blueprint there where equity of access and outcomes was placed highest, and there was also a commitment, to also value the workforce as a taonga, as a real treasure, because without a workforce, you cannot deliver a good service. But it just seems like what we've seen is quite a lot of turnover of leadership at the top of Dr Orna and the Ministry of Health, while conditions for patients who are waiting longer to be assessed or to have their needs met, conditions for them have not improved. So there's a whole lot of noise, noise and fury going on, but not a lot of outcomes. And there's one thing that really sums it up. I'm organising a discussion evening on what makes a good death, in my local area in a couple of weeks' time, and I've got 3 consultants coming to speak who all work in different hospitals. All 3 of them still have a DHB email address, so that probably says it all.
We often hear about how there's a lot of money involved in the taxpayer paying money into the health system, and we're hearing currently a lot about how from the government that the problem isn't about more money, but when it comes to primary care with GPs, there's a capitation system, and that is, my understanding is it's like a subsidy, but it means that GPs are having to increasingly get more and more people to the point where they're overloaded, and we're starting to get this point where people really don't have the same kind of access that they used to. Are you seeing that happening at all?
We know that access to primary care, whether you see your GP, your nurse practitioner, your practice nurse, is getting harder and harder. Between 30 and 40% of GPs' books are currently closed around the country, creating a myriad of difficulties. I mean, if you move regions, you may not be able to register with a GP, which means that you may have to continue with your old GP and see them via telehealth, if they will allow that. That can be difficult because, for people with complex conditions, you do need to see them face to face on a regular basis, and it's not always safe to be giving care solely in a virtual manner. And also patients really value face-to-face contact. So one issue.
I've read that it's actually better for your health to have a family doctor that knows you, that you might be diagnosed sooner with or avoid problems.
There's no doubt about that. Continuity of care is the hallmark of general practice and primary care, and there is no substitute for that. You absolutely, if you have a health champion, someone who's got your back, somebody who knows you, they will be able to recognise more quickly if something is going on. If you have a better relationship with someone, you feel more comfortable disclosing potentially difficult or sensitive information. You have a degree of trust, and you don't have to keep telling your story as well. So continuity of care is the number one thing which reduces morbidity and, yes, extends healthy years of life. So what's very interesting is this whole health reset started top down. So it started at the very top with changes in leadership and then, abolishing district health boards. But really it should have started from the bottom up rather than the top down, because general practice has needed a complete overhaul in New Zealand for a long time. A primary care strategy was produced in more than 20 years ago, which has never been enacted, and it still stands as a good document. And there is no rocket science here. It's well known all across the world that good primary care saves lives and saves money. I mean, that is the bottom line.
Yes.
I mean, I know we've talked about this statistic, but every dollar spent in primary care saves up to $14 in health costs. And this is because we look after people before they get sick, so before things become expensive. So,
yes.
Coming in to see us about your blood pressure or, any one of a myriad of things means that we can also, while you're there, we can go off on a tangent and maybe pick up other things. So it just doesn't make sense that general practice is not more valued. But really, that's not the sense that we have been getting in primary care.
Yeah.
So there's a few difficulties which I hope they're surmountable, but until general practice is properly funded and we have a proper plan as to what it's going to look like in the future, we are going to continue to have poor health outcomes, particularly for our Māori and Pacific populations.
I'm hearing the Prime Minister this morning talking on News Talk ZB radio station about the idea of getting more nurse practitioners into general practice, and ideas like having a longer time between having to go and get your prescription repeats. is this kind of like just Band-Aid ideas? I mean, what do you think really needs to happen?
Well, I mean, these are two aspects of probably a 2,500 point plan for primary care. There is a whole overhaul needed. You mentioned the capitation system, so that let's you get back to basics. How are GPs paid? Probably about a third of the money that comes into primary care is publicly funded from Te Royal Health NZ. But that what primary care is funded has not increased with inflation for years. So,
Right.
year on year on year on year, it gets more expensive to offer primary care. And so some practices have had to, well, a lot have sold to corporates. Some have had to shut up shop because they're no longer economically viable. This is the reality. So the funding is not fit for purpose. This formula that was come up with about how to sort of fund general practice is a flat fee paid according to how many patients you've got registered. So obviously, it's in your interest, say as a corporate, to register as many young, healthy patients who never need to come in to see the GP or the practice nurse as possible. But because really your capitation will cover 2 visits a year. And of course, if you've got an older patient with a multiple number of conditions who needs a lot of your time and input, that you might see that patient 12 or 15 times a year, and that will just be to see the GP or the practice nurse. That won't be all the other touch points within the system. So you can see that if you are a corporate business, you may not be so keen to enroll some of those patients because they'll be costing you money. But that's not the way that it should work. The public health system is for everybody.
Yeah. One of the things that I am looking at is a government that's come into power for the last year or so that immediately did things like repeal the smoke-free amendment legislation that would have immediately restricted a whole bunch of health issues that would have cost in the future all sorts of extra costs for the health system. And instead they started using big tobacco narratives, and they even gave big tobacco a $211 million tax break while arguing that there is no more money for health right now, and struggling to find money for cancer, etc. I mean, essentially, do you think we have the right team in power at the moment that they actually care about sorting out these very fundamental problems that are creating a crisis, even at the very front end there with your GP, when we're seeing all that kind of behaviour?
It's quite a difficult time to be in health because I think the narrative, as you say, often is at odds with what we're seeing in reality. I mean, New Zealand was really well respected around the world because of the COVID response. I know it wasn't popular amongst every sector, but the fact is the response that New Zealand had saved an enormous number of lives. And we were also envied because of our stance on tobacco, with the aim of being smoke-free by, was it this year, 2025?
Yes.
So to have that particular legislation rolled back, I think was puzzling to some countries that had looked to us for public health guidance. We've always had a very strong public health voice, and I think that has been quite disappointing, because if you work in a system that shares your values, you will throw your heart and soul into it. If you find yourself working in a system that suddenly doesn't share your values, that's quite discombobulating. It's almost Orwellian,
yes,
in a way.
Yeah, I'm not surprised. I mean, it's just quite the opposite of what I think many in the public would expect a government to be doing. The health board has been basically the people at the top of the Health New Zealand the board has been demolished, and recently we've actually started to see other people in leadership like Diane Safati, the Director General of Health. We've seen the Director of Public Health go. We're seeing a change in minister at the top. We've got a commissioner in there who's supposed to be coming up with a plan to reset health. I've personally heard a story that that health plan hasn't actually been quite what people expected, and now they're setting up a new task force. To be honest, it sounds like it's a circus to me, that they don't know what they're doing, and they've cleaned out all the experts, and it must be very, very difficult to work in an organisation that, or working in a system where you're seeing what looks more like sabotage than it does turning the ship around. It's probably quite political to ask anybody within the system these kinds of questions, but what do you actually make of the idea that health targets and waiting times are going to be the success factor if Simeon Brown, who I call the ruthless Minister of Health, because his ruthlessness was the quality that was publicised the most when he came in to that role, is trying to pull off here that, you know, he's focused on patient outcomes and waiting times will come down. What do you make of that?
Well, you know, targets are just there for target practice, really, aren't they? I mean, do they result in meaningful outcomes for patients? That's really what I would want to know. I worked in a system abroad for many years, which was focused on targets. And again, I think we all know what's been happening in the NHS, which has been a bit sad to see.
Yes.
I suppose I would be more interested if the focus was on creating a truly accessible and equitable system which started at the bottom. So how can you access timely help when you need it? How can we save money for the health system with proven initiatives like screening, high-risk populations, screening them earlier? These are unglamorous, but this is how you save money in a health system, not with constant, deck chair shuffling and targets. I hope I'm not speaking out of turn here, but it took forever to get cervical screening is still not funded for women, by the way. They still, I mean, it's wonderful that we now have HPV self swabs available, but you still have to do that. You still have to come to a medical premises to do that mostly, and you still have to pay for it mostly. So that's inequitable. We've got bowel screening, which starts too late. All of these are things which actually save money and lives. We should be screening for lung cancer, cheap tips, and would make a real outcome, a real difference to outcomes. So it's a little disappointing. But when you talk about leadership, there are still really excellent people working within the system. They probably just aren't making headlines because they are in the back rooms working as advisors, just keeping their heads down, trying to do their work. It's difficult to see with this huge turnover where the next generation of leaders will come from, because New Zealand is quite small. It takes a very long time to grow leadership, and it's not just leadership, it's skin in the game. So you have effective leadership, which means you need good relationships within the sector, and you actually need some relevant experience. When you have a culling of leadership in a small country, I think it makes people reluctant to stand up really, and offer themselves as the next leader. Health is always seen as a bit of a poison chalice. It really needs longer term thinking. It needs a long term plan which sits outside political machinations, because health is not right wing or left wing. Health is just the right thing to do for the right people.
Yeah. We keep hearing, people watching now, watching G News, keep hearing that politicians are saying there is actually no freeze on the workforce, that, you can just go out there and hire replacements. But we keep hearing doctors and other medical professionals saying that's not true. And so the public is just sitting back going, what is going on? Who is telling us the correct story here? And we're starting to hear stories about people really having like bad health episodes because the resources have been prevented from actually joining into positions that are just sitting there vacant. And this all seems to be about putting some kind of monetary outcome in front of the health outcomes. Have you got any comment about that kind of thing going on?
Well, it's my understanding that in an attempt to save money, many departments just simply do not advertise roles which are sitting empty, medical roles. I know this for a fact. We see senior medical officers posting on forums that there are jobs available in their departments and inviting people to share this with their contacts in New Zealand and abroad, because their own departments do not have a budget for advertising, or maybe only advertising on local sites, as in, just on the internal network, internal Health New Zealand network. So it's quite outrageous, really, when you find the staff are having to their own jobs. That is genuinely what is happening. What else are patients noticing? Well, patients come back to me. I mean, I do spend a decent proportion of my time re-referring patients because either referrals are rejected due to what's euphemistically known as capacity issues, or the waiting time is so long that patients deteriorate while they are waiting, so they come back more unwell than when I first referred them in, and then I have to re-refer them again. So this uses up a lot of time. The other thing that we've noticed is increasingly when patients do get in to be seen in clinic, they are being offered a self-pay option. So I can tell you one example of that only from recently. A very fit Pacifica man in his 80s who had been waiting for a knee replacement and now pretty much was unable to leave the house, finally got to the top of the waiting list. And when he went there, he was told, you need this, but it's going to take 2 years, but we can do it for $40,000 at this private centre. So it makes me a little uncomfortable that people are now openly being offered a self-pay option.
Yeah.
Because the public system can no longer do the job that it was once able to do.
I keep hearing as well that, from the national government at the moment, that there's just a whole bunch of bureaucrats. There's a whole bunch of layers in the way. There's 12 to 14, it used to be 14 layers of management at Health New Zealand that included the patient at the bottom. They were a layer of management as well. And that consequently, they were going to go in there, they'd seen the org chart, and they're just going to basically slash and burn this supposedly terrible botched merger with loads and loads of extra resources just sitting there, a bunch of administrators, and that there was enough money, and so that we just keep hearing these narratives all the time that suggest to us that Nobody in the front line is being affected at all, that everything's just tickety-boo, and that they're just targeting kind of people that they consider to be surplus. And it doesn't seem to connect with any medical person that actually works in the health system, who's basically working their ass off all day and going home exhausted and waking up exhausted the next day, trying to help people. And, we just keep hearing, frankly, it's just bullshit, I think. And I think we just need to frankly say that it is bullshit that we're all listening to and not put up with it. What do you think?
Well, I think the layers discussion was a little disingenuous. And there's been a narrative that the only people we should be paying are those on the front line. Like, people who are on the so-called front line cannot work unless they have someone has their back. So, if we don't have the data and digital capacity, if we don't have booking clerks organising clinic appointments or, booking people in for radiology or other investigations, the doctors and nurses cannot work. If we don't have cleaners, it's an ecosystem. It's ridiculous. Ripping out layers just causes the mine shaft to collapse. So these are just window dressing, isn't it? It's just noise, just to create fury, like we were saying. But when the dust settles, the patients will still be there needing what they need. Those of us who are left standing are still going to be doing our best with what we have. But it's clear that patients are having to pay more and more out of their own pocket. And, going back to what we were saying about funding of primary care, because the funding hasn't increased in real terms for years, but the costs have increased, the difference is made up more and more by patients. So patients are paying in a lot of areas $80 now to see their GP. So they're thinking twice about whether they need to go or not. The people are presenting later with more complex conditions, and that costs more to the health system. And this is why primary care, it's probably too late for New Zealand now, but the principle should always have been that it was free at the point of access. It made no sense at all to have patients paying out of pocket to see their primary care clinician, but nothing to go to A&E, or once they're referred into secondary care, the costs are invisible. Those things are more.
So in this political and fiscal environment that we find ourselves in, it keeps coming back to this idea that politicians need to listen more and get out of the way, that we need some sort of bipartisanship, some kind of long-term commitment to a strategy without mucking it around and changing it, and putting the money in the right place, putting the money, like you say, in the right place. There's a whole bunch of no-brainers there, aren't there? And the public, really needs to kind of like give the feedback to people that it's not going to put up with this. Something along that. People just really need to get like a little bit more active now, don't you think?
It would be wonderful to see anyone who has ever come into contact with health services having a think about what they would like those to look like ideally, and perhaps making their feelings known, either by writing to their MP, letting them know how important a good health service is, or whatever other kind of concrete action you could suggest. Because I think you're quite right about the health workers not necessarily being listened to. I mean, certainly we have found that with Women in Medicine. We've worked very hard to bring the voice of clinicians up the chain, and we represent our patients. This is not all about us, the workforce. We are representing our patients and the services that they are entitled to. But it's been quite difficult to cut through. Actually, I would say recently we had a very good relationship with the last two health ministers. It's been a little more difficult to present the current challenges to the current incumbents. So I would love to see patients take an active part in. Well, I mean, I always love it when patients take an active part in their health, and that's what we encourage them to do. But actually, maybe take an active part in their health advocacy, because genuinely, we are in danger of losing the health system that we have had here in New Zealand for a long time, and it's very precious. It has been a really good health service, and 40% of the doctors working here qualified abroad, 41% actually, and a lot of them are from the UK, like NHS refugees. And I think none of us want to necessarily see the hollowing out of another public health system on our watch. It's to be cherished. So
great.
Yeah.
Well, speaking of activism, and let's talk about women's health in New Zealand. What is the New Zealand Women in Medicine organisation, and what does it aim to do?
So we are a charitable trust centred on supporting the female medical workforce via connection mainly. And increasingly, we have become involved in advocacy, because that's where our members have made it clear that they feel there has been a bit of a vacuum. We don't have a New Zealand Medical Association anymore. That was a pan-professional organisation which represented specialists, secondary care hospital doctors, and primary care general practice specialist doctors as well. But that organisation folded several years ago. When Women in Medicine was set up, we literally were set up just around the time that the pandemic began, sort of 2019, to foster a greater sense of collective belonging. And because really, once you are connected, you can achieve a lot more. You can support the workforce, but actually we are a group of very articulate, impassioned individuals working at a very high level in our field. So we probably have an opportunity also to do some good for the general population, actually, because like I said, we also represent our patients as well as ourselves. So that's why we were set up. So what do we try and do? We advocate for the health service, for the health profession, but also we have a special we have a lot of energy that we put into supporting women and children's health as well. So we submit on a lot of things which affect women and children's health. We submitted asking for consideration of a women's health strategy, and we were successful in that. We weren't the only people advocating for that over many years. Women's Health Action were supporting that as well. But that's one of the things that was included in the PIRO legislation. Of course.
Yes. What is the strategy? Sorry, what is the... talk a bit more about what would that strategy look like?
Well, first of all, it would be an acknowledgement that women's health requires a set of parameters, of key performance indicators, because basically gender is a determinant of health. So there are several determinants of health outcomes. So income and ethnicity are ones that we know about. If you are poor, if you are Māori or Pacific, if you live in rural areas, these all determine what your health outcomes will be. Gender is another determinant of health. Women, very interesting, because when we first began talking about this with political leaders, what we were hearing back was, well, why would you need a women's health strategy? Women live longer than men. Really interesting.
Wow.
Such a concept, because I mean, this is what I mean about trying to keep politics out of health. I mean, I would not dream of talking about anything that I didn't know much about. You wouldn't be interviewing me on the economy, right? So I just find it really interesting sometimes that people in politics feel that they know about things that they really don't know a lot about. So yeah, women in general live longer than men, but they suffer enormous health inequities. If you look after women's health, here's another statistic for you. So if you every dollar spent on women's health saves more than $10 to the health service, because you are looking after women during pregnancy and the risky postpartum period. You can support women who have problems with very heavy, painful periods. You can keep them in the workforce, thereby contributing to GDP. I mean, the list just goes on. So, just to give another example, endometriosis, really common condition, probably affects 1 in 10 women. The average woman takes 9 or 10 years to be diagnosed, thereby often living in chronic pain, days lost to work, days lost to the economy. So these are a myriad of reasons why a women's health strategy was needed. Maternal mental health is another one. The biggest cause of death in the postpartum period is maternal suicide. We have a shameful record there. So anyway, as I say, the women's health strategy was passed as part of the PIRO legislation, but we've heard nothing about it since at all.
Yeah, that's terrible. That, we've actually gone there, we've thought about it, we've planned to, we've written all the reports, we've organised an organisation to do this, and then we've just torn it all back down again and started back where we were. One of the specific areas facing women that includes some gender biases around contraception. I was reading a little bit about long-term contraception, for example, and also how DHBs used to kind of apply criteria, and it was quite variable and quite siloed, but it was a little bit abstract and wasn't really based on, I guess, what you would call, the healthcare of everybody. What do you have to say about that particular area?
Well, it's still quite difficult for women often to access the contraception that they need. And I mean, this is, half the population, most of whom will need this like really basic intervention at some point. And again, contraception is one of those unbelievable public health interventions which saves far more money than it costs. We still do not have an effective way to train doctors and nurses to fit contraceptive devices. We don't have a nationwide scheme to do that. It's definitely better than it was when I first came to New Zealand. We were shown a YouTube video. I mean, I trained in the UK, where you have to have gone through a rigorous training program and do a certain number of procedures a year to stay registered, and you cannot fit contraceptive devices like implants and IUDs without doing this. This was an alien concept to New Zealand, and it's still not widely accepted. And yeah, I find it difficult to understand why anyone would want to do a procedure that they hadn't been effectively trained in. But again, this is probably something that has to come from patients. I think, if patients don't mind that, then it won't change. But we're probably getting sidetracked. Some of the research that I did was looking at the inequities in access to contraception around the country. And what we did find was, again, using DHBs were all given money from the government to try and increase access to contraception. But because there has never been a national strategy for women, which would necessitate applying clinical equitable criteria, if there were to be any criteria for access to contraception, DHBs kind of went ahead and picked their own criteria, and some of those criteria were very confronting. When I and the team I was working with researched that, some DHBs were funding it for women who were disabled or who were high users of maternity services. So in other words, people who had possibly what they would consider too many children, women who had alcohol or drug problems. You can see how these, if you were a GP explaining to a patient in front of you that you could get something funded only if you fulfill these criteria, you can imagine it would be a very uncomfortable conversation. But as far as I know, those criteria do still stand in a number of areas, and that's a little difficult to sit with, I suppose, because it does also go against the WHO's criteria for equitable access to contraception and lack of bias in access to women's health services.
Yes. Maternity services and equal pay and those early years where health gains couldn't absolutely be made. I keep hearing that we've got a midwife shortage, we've got no maternity records. Is that still the case, that you can't share maternity records around the system at the moment?
Yes, unfortunately, it is. The community maternity system, community midwives sit outside the public system. So a lot of midwives are independent midwives. So their computer systems that they use don't join up. So we, as say GPs, we don't have access to midwifery records, and they don't have access to our primary care records. So there is a danger there, or at least there's a risk. I would say there's a risk. It's much safer for patient records to be accessible by the entire team who is caring for a patient, and certainly for women who are pregnant. I've previously been used to a shared care arrangement where the GP would offer some visits and the midwife the rest, and we all use the same records, which are actually patient-held records in the UK. So everyone could see what the situation was on any given day for that patient. Unfortunately, that's not the case in New Zealand. Again, it's something that's been talked about for years. Many things have been talked about for years. It's hard to say what progress has been made. I haven't heard any further about integration of those records. We basically need a single integrated digital health record. That's what we need for the whole country.
And yet I've just heard that they've just slashed a whole lot of jobs in IT and health, and all these projects that were going to come have now actually been dismantled. It's the kind of thing, that we're hearing is, this almost like the worst possible thing you could think of doing. So we go and do it to save some money, to produce a result, political result for people.
I suppose, Gerard, I've answered lots of questions. I'm going to ask you a question now.
Sure.
So, for anyone listening to the podcast, what would you think that your sort of politically engaged listeners who may have touched the health system themselves at some point, what would you think they could be doing to make things work better? Do you think it's possible for any individuals to make a difference?
Yeah, I think that the whole thing to start with is just to actually talk about these issues and have absolutely frank conversations with each other and politicians about what's going on, because it's our service and it's our country, and it's these inequities, the kind of problems that we can solve, but we seem to be being prevented from solving them. We've got the money. We can actually go out there and raise enough money to fund these things and to push the money into the right places. We could fix things like the capitation. We could bring sort of the screening services you're talking about further forward. We could strengthen a whole range of things. We could pressure the people who are in politics today to come to partisan agreements. We talk about this in infrastructure because every time in the political cycle that there's a change of government, what we start to see is that one side sabotages the other and has a different set of ideas or values, and that's not working for the normal people out there that need to go and see a doctor. I mean, I would personally think that a lot of people would like to be able to talk about all their issues with their GP and not have their GP exhausted, and be able to access their GP if they want to see them tomorrow, and not have them having to work so long and hard without a holiday, and for women to be able to access all of the human rights, which, contraception, for there to be no more period poverty in this country because you're poor, you can't afford things, or any shame. I think that's what people want, and they want to believe in the leadership, and they believe in people that are being pushed off the edge, off the cliff at the moment, and it's just wrong. And I'd really like to see people realise this is a crisis that's been going on for a long time, but it's getting to the point now where, as you said earlier, we are in danger of losing something very good, and it's just becoming intolerable. So I'd like to see people at G News become more active, be more vocal, speak out to their politicians, be more active online, be active in conversations in their own families, in their own communities, with their community leaders about what it is that we want to have to happen. We need to decide. I think I heard you say once, Orna, that we want a champagne health system, but we're only paying beer money for it, and I think that's actually absolutely spot on. And so
it does. I mean, funding is definitely one thing, but also a really frank conversation about what a good public system looks like and what it can realistically do in a small Pacific country. So being very realistic that we are, we're not the US, we're not Australia. We probably can't do everything in the public system. And one country that has had this conversation is Holland. So Holland, there's some things that they have decided they can't afford, so they don't fund. I was listening to a podcast recently where I discovered what I didn't know. So neonatal care, at the moment, survival rates for very low birth weight, very, very premature babies, those survival rates have been increasing hugely over the last 20 years. But the long-term outcomes sometimes for those children are complex, and it's very expensive. And Holland actually made a decision that they weren't going to resuscitate babies under 24 weeks because of that. That's having, those are difficult decisions to make. They are difficult, they are painful, but they were looking at the public system as a whole. I don't think New Zealand has had the conversation as to what this small country can genuinely afford on the public system, and those things have to be cost effective, and that includes really good screening and early interventions, early treatment of serious disease. But are we spending too much, like most countries do, on the last weeks of life, for instance? We know that the biggest health spend of your life, like something like 30% of the entire health spend of your life, is going to be in the last 3 weeks of your life. So that's something that's been discussed beautifully by Atul Gawande. I don't know if you know him. He's an American surgeon and a writer, and he talks a lot about that, obviously from the American point of view. But it's something that's happening here in New Zealand. So I suppose I'm interested in a conversation about what a really good public health system looks like and what we can afford. And it's not a political conversation. Again, it's not right wing, left wing. It's a long-term conversation to be discussed with really good data and not in a populist way.
Exactly. Thank you very much for joining us here today, Orna. And I think it's been a very interesting conversation, and we'll start more conversations as a result. Thank you for coming in, and hopefully we'll see you here again.
Thank you very much.
welcome to G News, the good news.